continue on with digestive anatomy. So the plan of attack. So everybody, in case you're wondering, I will be here for the exam Monday. It would I would like it if a handful of you people try not to blow off the lab because it's going to be a fun lab. Dr. Buxton's bringing his students in, so we'll have some fun with technology. Okay, we'll do some fun stuff. It's stuff that we'll redo in physiology, but it's to help him to get some of his photographic physics class. So it won't be anything that'll be mentally taxing, because I'm sure you'll be want to be mentally untaxed at that point. Okay, you're cordially invited.
There's no lab, but you want us to keep
Well, yeah, there's no. We're going to be doing experiments that we'll probably do again. But I'm giving him something to do. Normally, I can sit there and talk to you about the urinary tract if you like.
No, that's all right. I'll be there for Dr. Buxton.
There's a hidden message in there, comma, but not for you.
I'm in class for you all the time.
Yeah. Or what a challenge.
So I have a question
Yeah, who doesn't?
about our lab final.
Yes, ma'am.
Like, is it the
Similar format to the lecture, to this last lab final. It's an
online?
easy slam dunk, dear.
Is it online?
I'll send it to you. Yes.
Great.
Are you good with that?
I think I can do that.
You can do that.
Yeah.
The whole idea is let everybody get an A. Can we deal with that? All in favor of that? Stop. Don't pull your hair out.
I might be losing hair. I'm gonna be.
Don't joke about that.
We should just do an open note test.
No, we're not doing. Never ask for an open book test because you never. There's always go bass backwards. Yes, sir.
So is the lab fine with the lecture?
No, it's two separate grades. And it's always been that way here. Micro lab, biology lab. You can get a C in the lecture and an A in the lab. Hopefully, you're all going to get B or better in the lecture and A's in the lab if you just do them. Work. Yes, dear.
But on Blackboard, like,
Ignore it.
okay.
Just look at the grade. All you want to do is look at the grades for. If it says like lab exam, it was out of 30 points, right? So if it said you got 29 or 30 out of 30, you've lost 1 point out of 100. I'm sure you can hold the fort with basically open book exercises, slate like exercises.
Yeah, I think I got it.
You think you probably can get an A. I'm not yeah, but if you don't show up immediately on time every other class, you'll be an F. So are we good back there? Everybody, okay, so you answers, okay. Can we start the show here? Thank you. And my wife has an interesting day, and we've been recording all this. Yeah. So skip through the first couple of minutes before we get to the serious stuff. Okay, your throat, your pharynx. Very straightforward, nothing special about it. Oral, laryngo, naso, pharyngeal constrictors, stratified squamous. Because food is in a roughened state. Okay, these are muscles that run in such a way, but these are muscles, these are skeletal muscles, so they're voluntary control. And there's three of them: superior, middle, and inferior constrictors that allow us to swallow. Done. We visited that in respiratory. That's where it's more pertinent, I think. Because now the esophagus at the divide, as we talked about in respiratory, the epiglottis, when you swallow, directs the food, what we call the bolus, BOLUS of food, down the esophagus. The esophagus is this wonderful design that allows it to expand. Did you ever see one of those hoses they used to advertise that, they were like this big, and they were like, once they started to fill up, they were almost like a 50-foot hose. You can find them at Home Depot, or they used to show them, one of those as seen on TV deals. That's basically what a lot of structures are with this fan folding. Basically, you're going to see this repetitively in a lot of areas. You'll see it in the ureters similarly. So they can expand when they're filled with fluid or food or material, and when they're not in use, they contract. It continues to be stratified squamous epithelia, and abruptly, upon becoming the stomach, it changes to simple columnar with goblet cells. The two are totally incompatible. When we get to the physiology, stratified squamous cannot tolerate the acidity of the stomach. The simple columnars and the mucus, which happens to be alkaline in nature, play an important role, but not the only role, in preventing when you get gastroesophageal reflux, acid reflux. That's acidity coming in. It's sort of geysering up and squirting back into tissue that can't tolerate it. And we call it heartburn because it's in the area close to your heart. You're going to see that anatomically. All of those things, agita, indigestion. You know, the generic term is GERD, gastroesophageal reflux disease. It is nothing to be taken lightly, by the way. Understand when you mask it with swallowing a lot of Tums and stuff like that. Take it from someone who has vivid proof of what can happen when you ignore those things. So here you have, and basically where it narrows and the smooth muscle thickens is called the cardiac, because of its proximity to the heart, or gastroesophageal sphincter. It's not a classic valve, it's just a narrowing, and it narrows sufficiently to block the passage of, basically to close sufficiently so that acidity can't geyser up. Keeps the orifice or opening closed when food is not being swallowed. And again, it's protective from the acid reflux. The esophagus has the same layers. It just doesn't perform the absorption portion. We don't absorb things. We don't mechanically digest or absorb anything or chemically digest it. The esophagus, for lack of a better way to express it, it's just a tube. Okay? Changes from simple columnar at the stomach. The glands in the submucosa just basically have a lubricating mucus. Okay? It's skeletal muscle roughly through the first 2/3. And when you get to that last third, smooth muscle and peristalsis takes over. So once you get it down far enough, now peristalsis takes over. And again, because it's a dry lining, it's called adventitia, where serosa is the moist lining that we had talked about. See what I mean? So here you can see the layers of muscle externally, circular. Here you can see the circular and the longitudinal. You can see the bundles lengthwise there. You have the submucosal lining that's there, and here you can see the cells. And so these, you can just imagine how these can expand appropriately. That's the reason why, if you think of it that way anatomically, if the tracheal rings were a solid circle as opposed to be C-shaped and having that trachealis muscle, we've all, maybe you haven't done it, but I used to eat a lot. Still eat a lot, but I used to really eat a lot. You'd have the 2-bite sandwich, and and all of a sudden it's like, oh my God, it'll never get down. We've all done that periodically. Most of us have. Imagine if that's sort of this. We can expand it as is necessary. So it's a very, very interesting type of thing that goes on. It's a beautiful illustration of what happens. It's a bad illustration here because it's not here, it's down here that it happens. But right here, there's simple squamous non-keratinizing, and here's simple columnar. These indentations are those we call gastric pits. This is the lumen. This is the interior of the esophagus. This is now the interior of the stomach. So you can see the transition between this thick lining. You can see it's non-keratinized because you can see here, you can see nuclei. And then now you get simple columnar. And you're going to see when we look at the simple columnar, it has a brush border because for surface area, they have a lot of microvilli. So basically, it's just, again, it's an adaptation to increase surface area. There's a ton of surface area. GE reflux disease, GERD, okay, all kinds of things. excessive food, drink, obesity, pregnancy certainly is part of it. Some runners experience it. There's no way to quantify it. Certain foods are more some people can tolerate foods of certain types, some can't. Some foods are very, very highly acidic. Uh, Medications that you take, stress, all play a role in this. Everybody, they manifest things differently. I mean, my middle child, when it's something emotionally, he has to express it. He has to ventilate. He's one of those, when something goes his way, he's gonna text somebody, he's gonna post it. He's one of those. He's gonna write a Google, he's gonna slam somebody, get out of the system. I'm trying to, it's sort of like he hits the send button before he thinks. And so everybody has their own faults. I mean, I tend to internalize those things that go right to my gut. And I'm saying this, you truly. I mean, there's a lot of ways to vent. If exercise does it, do that. Sitting there, watching a movie if that just chills you out, do that. Be very careful. Find ways to deal with that stress because it will just clobber you. And unfortunately, life is full of those stressors. You're all looking. Has anybody told you this before? Your moms and dads had to tell you this before, right? Stuff happens. They used a different term for stuff. Okay. Pharynx and esophagus are conduits, passageways. Major function of both organs is propel it, swallow. There's different phases. Don't have to worry about it. I don't do it in physiology. Don't care. Don't care. Don't care. Don't care. Don't care. But here you can see how it's closed. That's a good illustration. This is the stomach. The stomach sort of, they call it a letter J shape. It's curvilinear. It's convex on the larger exterior boundary, pointing sort of externally or laterally sideways. And on the interior is more of a concavity. So that is typically the shape that's there. And we identified different areas, and we're going to get to that ever so shortly. It's really interesting. That's there. And you can see as food passes, then it opens ever so briefly, closes behind it so it doesn't regurgitate. And then and in small units tends to fill the stomach. I'm not going to go into, I want to go into the stomach is just this temporary storage. It's there. What goes on there is basically mechanical digestion. It's a giant mixing bag. You will see when we get to it. Pardon me. When it's, again, think of that fan folding thing. Think of that image of the esophagus. If you look up here, you see all those ridges? They have a great name. They're called rugae. Rugae. And rugae are ridges that occur when the stomach is relatively empty or being filled gradually. They are there. And you're going to see how the food, because of the muscular structure, passes over them. The analogy, and I don't know if your sink at home has it, and not if you have a sink down like we do in the cellar where the washer and dryer are. We have basically a scrub sink, old-fashioned sink, and it's got the ridges. It's got like a washboard built into it. You know what I'm talking about? That's your stomach. And I remember my grandmother doing this because it was a luxury to have a washer and dryer when I was a little kid, back 70 years ago. Easy, because it was before we were still living in the city. And I have my grandma, and she's washing it with a washboard with something called bluing, which was like an agent, like a whitening agent that was there. And I'm asking her all these questions about that. And that's kind of the way those things work. So your stomach does something similar. You're really breaking down all of the whatever the soil material she was doing, but here it's mechanically pulverizing this food in a bath of hydrochloric acid and a couple of enzymes, another enzyme to be able to start to dissolve fats. And the first time we start to dissolve proteins, we'll get to that in physiology. We'll talk about it a little bit here. We talk about the glands. So temporary storage tank, and what the end result of what comes out of there is called chyme. Chyme. It's sort of the running mate of the lymphatic stuff, which is called chyle. Remember me telling you that. Bless you. The empty stomach, less than 2 ounces, but can expand to a gallon. And the emptier it is, the more you see these folds called rugae. You will see them in the bladder as well. Same deal. As the bladder fills, they disappear. So it's really, again, it's this whole notion of fan folding with availability of space. I'll show you the regions that are described here. The part where the esophagus answers because of proximity to the heart is called the cardia. That is the cardiac sphincter where the esophagus enters. Okay. The dome shape that I'll show you lays under and kind of gathers its shape from the dome of the diaphragm. We call it the fundus. Dome-shaped structures. We have another one with a fundus that you'll see in male repro anatomy. That's the uterus has a fundus, a dome-shaped area. And sometimes pregnancies will be in that dome-shaped area. Okay, the vast portion of it is the body where all those ridges are. And then as it begins to narrow, it's on its way to something called the pylorus. Okay, it's wider as it opens into it. Superiorly, it gets narrow. Okay, in an area called the antrum. And then the exit point is called the pyloric valve or pyloric sphincter. Again, smooth muscles coming together, only allowing a little squirts of this chyme to come out, maybe a half a teaspoon to a teaspoon at a time. They are so acidic. They are so highly concentrated. Even those little squirts will be enough to trigger pressure receptors in the start of the small intestine, which is called the duodenum or duodenum, depending on where you want to put the syllable. Okay, and that will stretch it. It'll be alerted by the acidity, by pH receptors, and it'll be alerted by the osmolarity, by osmolar receptors. They will all trigger the physiology that basically converting it back to neutral in an environment that's highly alkaline from one that's highly acidic. If it's so acidic going in, the small intestine can't handle it. So what happens in those areas is a thing called a duodenals, which is different than a gastric ulcer. I will show you. They have a picture of what I had, and it's not a pretty picture. So be aware of all those, and this is where it is. So here's the cardia. This would be the sphincter would be here. So as soon as it pierces the diaphragm, it makes the change. Now it's stomach, and the sphincter is there. This is the fundus is that dome-shaped superior portion. Here you can see the greater curvature, the larger, which is convex, the lesser curvature, which is concave. You're going to see that there's soft tissue, okay, a layer of fascia or soft tissue with blood vessels and nerves, really a part of those mesenteries I was talking about. From the lesser curvature to the back wall area, from the lesser curvature to the liver, okay, and from the greater curvature, there's a layer that hangs down where, and basically it's almost like an apron covering the small and large intestines. It's got a fancy name that you will see called the omentum, omentum, or omenta. Sometimes people will refer to it, they're looking at multiple specimens. Again, you can see the ridges. This is the antrum. Starts to narrow here. We're getting into the pyloric canal, and the antrum is right about here. It really begins to narrow more. And then you have the pyloric sphincter, and the anatomy then changes, as you will see, when we enter into the first loop of the three loops of the small intestine called the duodenum or duodenum, which is the smallest, but is by far and away the most important. Moving on. Here's what it looks like an injected specimen. We'll see something like this when we do like I said, we only have 2 more labs. A fun lab, and then we'll have a fun lab for dissection after, when we come back from Thanksgiving break. You're invited there too. No, I have to wear gloves. We're handling trafe. No idea what I'm talking about. Judaism, we don't eat pork. Kosher. It's what it's. People say, "Oh, chosen people." The only place in a giant desert that doesn't have oil, surrounded by enemies, who want to destroy you, and you can't eat bacon. It's not fair. Choose somebody else. I know I am not a practicing person. That's why my wife couldn't exist without bacon. That's what she's got 5 food groups. That's one of them. So the word I use, treif, it means it's not kosher. Greater curvature, lesser curvature. Mesenteries extend. The lesser omentum is the part that runs to the liver, and the greater omentum drapes down over the small intestine, spleen, transverse colon. And what's interesting about that one, it's like an apron that covers it. In surgery, when they did my surgery or anybody's abdominal surgery, and they open this area up, you basically take this drape of fatty tissue and blood vessels and connective tissue and pull it out of the way carefully. When you do whatever you have to do, then you bring it back to cover it. That means there's an interface between, when we talked about adhesions with bowels sticking to each other, it's just as bad if the bowel sticks to the undersurface of the skin. This prevents it. There's a whole lot of little, it's the kind of thing, if you go into a field or you see about surgical things, these are the kinds of things that people don't think about, but surgeons think about. Surgical anatomy is a whole lot different than the anatomy we teach here. There's just so much that goes into it, all these little factors. Even when I was in practice for years, I mean, when I had a surgery day, I'd sit there, I put the X-rays up on a board, and I go, okay, I'm going to do this, but if there's something wrong here, I came up with like 3 strategies, depending on what they are. And eventually, like I was once told, hey, once you do it about 100 times, you don't have to worry about that. But for the first 50 to 100, man. Piss poor planning makes problems in performance. So you will see that. We'll get into the nervous system and the blood supply we talked about. Don't have to go there. The stomach contains all 4 tunics, except with modifications. The muscularis externa has circular and longitudinal muscles as well, but there's a 3rd layer that's oblique. And you'll see that here. Here you can see the longitudinal layer. Here you can see the circular deep to it. So when the food basically goes over and back, over and back, over and back, over this kind of a la washboard or ridges, that's really the foundation of mechanical as well as the peristaltic movement. Okay? That's why that's important. Together, smooth muscles allow stomach not only to churn, mix, and move chyme, but also to pummel it, which increases physical breakdown and ramming it into the small intestine. It seems overly vigorous, but it's really what happens. Typically, if you have, like, let's say you went out and had a regular lunch or regular dinner, rather than what a lot of us do is just grab something on the go and running between classes. 4 to 6 hours on average for the food to get out of your stomach. It starts to absorb, some stuff starts to absorb right away, and I'll get into that in a second. The mucosal layer is also modified, simple columnar, entirely with mucus cells. They secrete alkaline mucus because it's an acid environment. It traps the bicarbonate-rich fluid beneath it. Okay, the pits are these entry levels, these entry tunnels or passageways to these glands that produce the gastric juice. So this is anatomy, and we go back and revisit it for physiology. There's no interesting lab we do for physiology for this, because there's not a lot we can do with it. It is just filled with pits. It's as though you took like a pin and just started poking holes as close as you could to one another in the stomach. That's what the pits are. Tiny openings, and they're filled with these cells. They have 4 different cells, one of which we still do not know what it does. That is the mucous neck cell. Not clear. Parietal cells make 2 things. They make the acid. When you hear about proton pumps, those are what are contained in parietal cells. If you know somebody who takes Prilosec, Nexium, one of these proton pump blockers, A lot of people do that. I did that for years. Okay, that's where it attacks those proton pumps. Additionally, it produces a chemical called intrinsic factor. Intrinsic factor is a polypeptide that we must have if we are to absorb vitamin B12 through the gastrointestinal tract. Some people do not make it, and there's an interesting disease called pernicious anemia, which we'll talk about when we get to the blood part of the program. That pernicious anemia is indicative of B12 deficiency. So a lot of times it's not so much you're not getting the B12 in, you don't have a way of absorbing it. It's not life threatening now because we have injections of B12, we have nasal sprays with B. You can get it into your system. Other than that, which is where it is. With my multiple stomach surgeries, I have a B12 deficiency, so I typically take B12 supplements. You'll see when I'll tell you about it again when we get to physiology, because it causes an unusual kind of anemia where the cells don't get smaller, which is typical of anemia, but get larger. We'll get into that then. They have chief cells. The chief cells make pepsin. They make it in its precursor form. All proteolytic enzymes, not a lot of alls in the body, living system. All proteolytic enzymes are secreted in their inactive state. And that means they're protein digesters. They don't say you only digest proteins in the stomach. You only digest proteins in the small intestine or the large intestine. So proteolytic are indiscriminate. If you put it on a protein, it starts to gobble it up. Right, and that's why we control them. So they're in what we call ogen form. The ogens, pepsinogen means inactive or precursor. Chemically, what happens in the presence of hydrochloric acid, it's activated and becomes pepsin, the active form. Basically, along with some enzymatic action, takes off a part of it. We've probably seen some of this in biochemistry, where it chops off and it activates it. And now it starts gobbling the proteins, but in the protection of your stomach. So imagine somebody who has a perforated ulcer and this stuff starts pouring out, along with hydrochloric acid into their gut. Anytime it contacts an organ, it starts to gobble it up. They're all made out of proteins. It's horrible. What do I tell you about the pancreas and pancreatitis? It's even worse. So all that, I try to do this for the relevance. A lot of it is don't be, trying to think of a way to play. Don't be a stupid like I was. Okay? Please. I nearly croaked 3 times. And you wouldn't have been forced to endure these bad jokes. Me teasing Jenna endlessly. And I'm not making it up, it's very true. Very true. Chief cells and then enteroendocrine cells. This is another unique thing about the gut. We have endocrine means they are directly released into the bloodstream. The hydrochloric acid, the pepsin, the intrinsic factor is released into the gut. They are called exocrine glands. They have a little passageway, which I will show you. These endocrine glands are surrounded by blood vessels on the exterior of the cell. It goes right into the bloodstream. Interestingly, it's made by the stomach and it works on the stomach. Okay. So we talk about different kinds of hormones. These are called autocrine, self hormones that work on where it was secreted. There's autocrines, paracrines, which work on adjacent, para means next to, and endocrine means they're carried all over by the bloodstream. Here it is. You have the lining cells here, the simple columnar. These mucous neck cells of unknown thing, parietal cells in this color, deeper chief cells with the pepsid, and then these little green guys are called enteroendocrine or G cells. They're called G cells because the most important of these chemicals is called gastrin, capital Gastrin, obviously named for the organ it works on, the stomach. So the gastrin, well, The parietal cells and the hydrochloric acid intrinsic factor and the chief cells and their pepsinogen go this way through a duct, exocrine. This goes into the bloodstream and little capillaries, yet it works on the other stomach itself. It's basically when something triggers your stomach, food's coming in, it triggers these cells to basically tell the rest of the stomach, we have company, get busy, clean up, we got to start to get to work. That's the way in my mind, I try to understand what goes on. I don't know if it makes sense to you, but it makes a lot of sense to me. To understand this is how the body communicates with itself. That's, at the same time, when you start to eat, immediately it sends signals down to the end of your colon and says, we got incoming, time to eat. How many times have you eaten something and said, boy, I got to run to the bathroom? Called the gastrocolic reflex. We don't always have to do it, but it sends a little signal saying, in case you got to go, good time to go. We got more incoming coming on. It's not pleasant to discuss. So mucous neck cells, don't know. Parietal, hydrochloric acid, pretty acidic. Denatures proteins, activates pepsin, breaks down cell walls, kills, and its big job is killing bacteria. Oh boy. It was the third time when I really was very sick. It was because I wasn't killing enough bacteria. That bacteria had a name. It's called salmonella. I got it when I was teaching a collegiate class. I'm still suspicious. It's all right, it wasn't here. So none of you are complicit. It was 2006, and I don't think any of you were in college then. Tease Jenna, but I won't. And so the intrinsic factor, a glycoprotein required for absorption of B12 in the small intestine, not the stomach. Very limited absorption in the stomach. Pepsinogen, inactive, activated by the hydrochloric acid, and a positive, one of those rare examples of positive reinforcement. And they also make lipases. Gastric lipase is made there so we can start to break down more of the fats. We started the fats in the mouth with the tongue, lingual lipase. Now we have more, and the rest will finish the job up when food gets into the small intestine. The enteroendocrine cells have serotonin and histamine. These are often neurotransmitters. Histamine is not just all about allergies. Histamine, we have, if you know somebody who takes like Pepsid AC or Tagamet because they have, acidity problems in their stomach, it works on histamine receptors. They're called H2. Because not all receptors are created equal. Typical H1 receptors are antihistamines you might take. And Zyrtec, like I take, interrupts that pathway someplace else. That's why it doesn't make you drowsy. But H2 receptors block this activity, which increases your stomach activity. Serotonin also. The paracrines may work locally, but the big player is gastric. Even somatostatin. Somatostatin is sort of what slows down growth hormone. When you're eating, you're going to use insulin typically. When you're not eating, you typically use growth hormone for repair and things like that. Your body, those two are sort of in competition for what you're going to grow with. When we're eating, our body makes the presumption that we're going to use the carbs first. And it always uses carbohydrates first. So it's all about insulin. And in other instances, whatever the type of diets there are, carbohydrate sparing diets like keto diet or Atkins diet or South Beach, all very, very similar. They utilize, basically, you're trying to limit that because insulin and using carbohydrates is very pro-inflammatory. Yeah, I mean, it's scientific of this. And so here you can see it again, a little more. Here's those enteroendocrine cells. The gastrin is the big player. The stomach is so harsh. It's not just the mucus. Here we go again with anatomy. The major player that prevents all isn't just the mucus neutralizing, it's still nasty. Those lining cells have tight junctions. Stuff can't get through. As you can see, they're under a lot of trauma and stress with acids, food, moving all the time. They're very actively replaced every 3 to 6 days. Every single cell, small intestine, large intestine, stomach, every 3 to 6 days. Small intestine the most rapidly. But billions of cells every single day. Gastritis, anything that breaches it, peptic or gastric ulcers, me, erosions in the stomach, perforate, peritonitis, if it opens up, and hemorrhage. Mine never opened up and let stuff get into the abdominal pelvic cavity. I had a lot of hemorrhage. That's why I have a lot of units of other people's blood given to me over a 2 year span. I would be getting periodically 2 or 3 liter transfusions. I was bleeding so bad. See, I used to have no sense of humor, and all that blood is, I must have gotten a comedian's blood. Thank you. For one person smiled. And this is, I'm trying to phrase this politically correct. Most ulcers are caused by bacteria, Helicobacter pylori. Bullshit. I had the world's biggest ulcers. Either one large one or 12 small ones, doesn't matter. I never tested positive for that. Now, if they said most people with gastric carcinoma are associated with or caused by Helicobacter pylori, I will buy it. There's a statistical association. A lot of us have Helicobacter pylori. Not everybody has ulcers, and people with ulcers don't always have it. My problem was this: non-steroidal anti-inflammatory drugs, aspirin, ibuprofen, Aleve, or naproxen. They're all NSAIDs. We have a ton of them. They all have one thing in common. Okay, to be an anti-inflammatory oral drug, non-steroidal, they all damage the stomach lining. Period. 70% of the people who take these long term over their lifetime will experience some gastric bleeding. Period. So they're not without fault. I ate them like candy. That is an ulcer. That is a big ulcer. So that ulcer is an ulcer anywhere is a defect in the tissue. Classically, when we say someone has ulcers, they're associated with this. This is what it looks like. Mine was larger. I was so sick the second time and bleeding so badly, they had to, through the scope, inject it with epinephrine to stop the bleeding and basically cause the tissue to close and contract. And I was in the hospital 9 days to get healthy enough for them to operate. That's how sick I was. So they were basically building me up and giving me blood and nutrients. That's how sick I was. And I was still teaching up until the day I went into the hospital. We'll get into more of that when we talk about the blood. This is the Helicobacter pylori. So this, all the different things, breakdown, holding, delivering the chyme, denaturing the proteins. These are all the physiology. We'll go over it. I'm not worried so much about the renin and stuff like that. Things, you wonder why things absorb through the stomach. Only things that damage the barrier. Non-steroidal anti-inflammatory drugs like aspirin, alcohol, caffeine-containing substances, coffee and chocolate, they get in pretty fast. So caffeine, all of those are things. And then when somebody has ulcer stomachs, those are things they tell them. Quit chocolate, quit caffeine, quit high acidic foods, don't drink. Probably the reason I'm still here giving you this presentation is because during those years, I never drank. I drink rarely as is. I didn't drink for about 15 years. Anything. No alcohol whatsoever. Not that excited about it. For cooking is a different thing. Okay? And if you think, when they tell you, oh, alcohol goes to my head quickly, it really does. You know what accelerates it? Carbonation. So champagne, you betcha. Beer, yep, carbonation does that. None of you would be familiar with this, I understand. Except the party girl over there. Conked out. Mustard. Here's the pernicious anemia with B12. Yeah, we'll get to this. Is all physiology. We don't do this, thank goodness. Don't do this, thank goodness. This is all phys. Fizz. 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 Mostly physiology is here. Proton pumps are. We get into proton pumps, and you'll see all of this type of stuff in physiology. I mean, it's really, it goes back. You see that wonderful equation again, that by carbonic acid equation. You'll see it again and again. It's the foundation of how we make acid, all of those types of things. How we make mucus, and this is, you can see, receptive reflex mediated relaxation. Okay, your stomach stretches passively. So if you eat slowly, you can get more in than you have rapidly. These are, we'll talk about this, sort of pacemaker cells that cause this. We'll talk about the chyme, all those things that are part of it. And this is the other thing. You see, when you overstretch it rapidly, that's what makes, some people vomit very easily. Intestinal irritants make you vomit. So that's why we shouldn't tell you this. People who drink alcohol slowly can hold a lot more than people who down it fast. So that's why we get people who drink and all of a sudden they're, oh, I got to go out and throw up. That's because your body starts to basically start to detoxify and deal with it, and it's less of an irritant. It's anything. Vomiting is a protective medicine. Excessive alcohol, food, things that immediately are sensed are bad, you'll send that reflexive response to, basically vomit it up. So there's lots of things, and the fortune with when someone has food poisoning and they're doing excessive vomiting, the big problems are dehydration and electrolyte imbalances. We get it with babies and Pedialyte and all that stuff. And in adults, you can use it with, all those various like sport drinks that have electrolyte replenishment. We're fortunate to have those that are now. And we'll stop here. This is liver, gallbladder, and pancreas. We'll pick this up on Friday. Important stuff. Don't want to start it new here.